Hi, and welcome to the Becoming Trauma-Informed podcast, where we help you understand how your past painful experiences are affecting your current reality and how you can shift those so you can create your desired future. I'm Dr. Lee, and both myself and our team at the Institute for Trauma and Psychological Safety are excited to support you on your journey. We talk about all the things on this podcast. No topic gets left uncovered. So, extending a content warning to you before we get started. If you notice yourself getting activated while listening, invitation to take care of yourself and to pause, skip ahead a bit, or just check out another episode. Let's dive in. Hello, everyone. Welcome to this week's episode. I'm very excited to have a guest here with me today, the amazing Dr. Amy King. I'm going to let her introduce herself in a moment, as I usually do. And I just wanted to give you all a little bit of background because I'm really excited about this because I'm going to be on her podcast. She's on our podcast. And I think that we met in email, and I remember seeing the email and going to look at your podcast. And I was like, how have I not met this human yet? Right? Which is always such a fun experience when you get to connect with somebody that you're like, I had no idea that this person existed. And also like, we got to talk. So I immediately replied back and was like, yes, like, let's do this. So Dr. Amy, you are also doing some really cool things in the trauma and the resilience world. And so I would love for you to just tell our listeners like who you are. And I kind of like the question of not like what you do, but like, what are you excited about that you're bringing to the world right now?
Yeah, I love the question. And I'm so happy to be here too. And I'm so excited to have you on my podcast. I think we got connected because I was scrolling through the Health Podcast Network and I'm like, I need to meet her. I need to talk to her. We need to be like collaborating on things. So I'm just like super excited. First of all, I'm a mom of two kids, 16 and 18. And I also have a daughter, a bonus daughter who's 26.
Awesome.
I'm a wife, and I'm also a clinical psychologist. So I've been practicing for about 26 years and moved into consultancy and training a little over 10 years ago. And it was really a call from all of the work that I had done with children and families who had experienced a great deal of trauma. And I'd always worked with that group of kids and families. It was a passion of mine. And I don't know if you remember, but in the early 2000s, Dr. Newberg gave a TED Talk around adverse childhood experiences, right? And it just blew up the medical community. Well, for those of us that had been working in that field for some time, it was her reflections on the original adverse childhood experiences study that really set it off. That is a study that I read way back in graduate school, right? It's one of many, many articles and books that talk about how childhood trauma affects folks later on. And I was contacted by a group of pediatricians who said, this doesn't seem like great news that, kids could experience trauma and it has a long-term effect on their life. What do we do about that? And so I began consulting with a group called the Children's Health Alliance and these incredible pilot pediatricians, Lee, and they picked my brain about childhood trauma and family adversities. And really, we decided, what do we do about it? We didn't feel like it was enough to just know about it, right? They felt like as physicians, we want to understand what trauma is, how it presents in healthcare settings, and but more so, we want to know, what do we do about it? And so I will never forget one of the physicians saying to me, really, I'd like you to build a curriculum for every well child visit so that we could mitigate stress and harm. And I said, okay.
I got chills. Like I have literal chills right now. That's amazing.
Yeah. And so it was just right in my passion wheelhouse of not just knowing what trauma was, but really having this population systemic effect on what do we do about it, right? And there are things we can do about it. There, building resilience, buffering relationships, being educated about intergenerational health, historical traumas, how trauma presents in kids and families. When we know about it and talk about it and give families strength and education, they do better. That's what all the research shows. And so I began doing this work and training physicians and now other healthcare providers and organizations and educators and law enforcement and a whole bunch of groups of people on not just what trauma is, but what do we do when we see it? How do we respond with efficacious research-based interventions that can be helpful and get people back on track should things go awry? That's what I do.
I can like feel the passion. And I'm also just completely nerding out over here because my doctorate's in nursing. And when people are like, okay, hold on a second, right? Like, how'd you go from there to here? And I'm like, because my real doctorate is in evidence-based practice.
Yes.
You know, I have a practice-based doctorate. And so I get so excited when I see people taking, when we talk about, I know you know this, but for our listeners, like when we talk about evidence-based practice, right, you've got the three legs to the stool of the individual patient or family's experience in front of you, your clinical expertise. And like you're talking about, you've been doing this for so long, you know, I've got a lot of relevant information that I can like filter this experience in front of me through. And then also the evidence, like the research that we've done. And it sounds like what you've created is just this really beautiful, well, pardon the pun, but it's what you've created is evidence of how helpful evidence-based practice can be, because you have to have all three of those pieces.
Absolutely. Absolutely. And the tricky thing, especially working with physicians, and you know this coming from healthcare, right, is like when you ask them to begin talking about trauma, they're like, wait, what?
Yeah.
You want me to, that is not in my wheelhouse. And once we began doing the work, once I began reassuring them, you know, you don't have to be a psychologist or a therapist. You just have to ask questions and then know how to respond in a way that's really strengthening for that individual. And so I took what I'd been doing in my private practice, you know, for an hour at a time or 30 minutes at a time or 90 minutes. And I took those research-based interventions and said, here's how you could do it in 3 minutes or 5 minutes in a well child visit and really have an impact on kids and families. And at first there was like some skepticism, like, I don't know if I can do that. And then what we saw happen through, you know, this was 10 years ago. Now we're on several iterations of this, but they went into their practices and they began doing this and they felt more competent. Their survey from parents and individual patients and families started coming back saying, we love seeing this doctor. He or she really listens to me. They hear me. They care about me. So their, you know, what we call patient satisfaction scores went up.
Yeah,
and their burnout went down.
Yeah. Which makes so much sense. It makes so much sense because I know I went into healthcare. I think you went into, I'm making an assumption that one of the big reasons you went into the work that you're doing is because we really care about people, right? Like you want to positively impact the experience that the patient or the client coming to you is going to have. Like they're going to feel better when they've left your office, even if you've not been able to do anything for them, they're going to feel better. And when I think about what is required for us to do that, it is that confidence and empowerment piece of, okay, I don't actually have to know all the answers. What this person really needs is to be seen. Yes. What this person really needs is for me to, you know, we use the word attunement, right? Like they need my attention, which how many of us go into a provider's office and we're like, you're distracted.
Yes.
Right? Exactly. You're not here. You're here, but you're not here. Mm-hmm. Those patients and clients, like they want our attention and they want our compassion and our understanding, like our curiosity, not our judgment. Right.
Yeah. Yeah.
And I don't know about you, but I wasn't taught how to do that in all of the courses that I took as a nurse. And even when I went back and taught, like that wasn't something that was a standard part of our curriculum. Was like, here is how you feel confident and empowered, showing your patients you care. And I'm like, man, if there's one thing I could go back and add into our curriculum, it would be that.
Agree. And you know, the thing is like everything that psychologists do, that's how we're taught and trained, right? To be attuned, to acknowledge feelings, to sit with pain. And that's not the medical school model. And I get it, right? In some ways, I have so much compassion for healthcare providers. I mean, with electronic health records and bureaucratic red tape, like they walk into an exam room, they've got so many things to cover. They're getting, you know, paid by, you know, the number of patients that they see. And so they've got like 5 minutes, 7 minutes, maybe 10 minutes with a patient. And I think especially during post-COVID times, if we can even call it that yet, patients are more complex than ever. And so it's not like they're just walking into a visit with a 5-year-old or 16-year-old or 34-year-old, and it's just like a ear infection or sinus infection. It's like, oh, yeah, I have this ear infection and I've been depressed for the last 6 months, or, and I'm going through a divorce, or, and my mom is dying. So it's not anymore a matter of like, it would be really great if you could be more attuned to your patients and put down all of the check boxes that are in the EHR that I totally understand, but it's necessity at this point, because there has to be a gap that gets bridged between what you're seeing in your office and any kind of outside resources or support or help.
Hearing you say that, I'm wondering, I remember one of the reasons I left healthcare was because there were a lot of places where I felt disempowered. Like even knowing that, okay, me being able to be attuned for a patient, that is so important. And I have 40 patients, right? I have 40 patients. I'm on hour 18 doing my 6th admission. Like I have nothing, like there's no attunement left, right? So I'm curious, as you're having these conversations with clinicians and you're saying, yeah, the burnout went down. Like, did you think that part of that was feeling more empowered? And I'm curious, do you feel like there were other factors that impacted that?
One of the physicians that I worked with, Lee, called this unlearning. She said, I had to unlearn what I'd been taught in medical school, right? And she said, here I am, I'm sitting in front of, often providers have, their computer in front of them or whatnot. And I have all these things that, Healthy Family says I should get through in this well visit, or, if you're an adult provider, all these things I should talk to, and make sure we're doing these colon screens and, all this anticipatory care. But the number one thing is, if you're missing something that's in the room because you're focused on getting through what's in the boxes, then ultimately it's going to take more time on the back end and or affect your patient's health that's going to circle back to you anyway, right? So you may have somebody in front of you with diabetes and you need to talk to them about, insulin and, medication management and all this kind of stuff. But if they are drinking more or eating more because they've got a lot of family stressors going on, guess what? You're just putting a little Band-Aid on by talking to them about, quote unquote, medication compliance. If instead you're saying like, what are you doing to be connected right now? Who are your people that you can talk to? Where are resources and support that you have? Have you thought about, chatting with someone, a therapist, a coach, a mentor, a religious leader, whomever, to really get to the root of what's causing the diabetes to flare up or to be, out of whack, so to speak. But often that gets missed in the room. So once there's just a few tools, right, of like sitting and listening, I literally do, like in my community that I've created called the Provider Lounge, I talk to them about the art of listening. Very few medical programs are teaching that, right? Just how we listen. And if we don't listen, then we miss those things. And ultimately, it's going to affect your patient's health anyway. So we might as well hone in and tune up some of those skills now so we don't miss the things that are happening later on. And it's going to have a much greater impact on your patient's health. So what ends up happening is the burnout goes down from these providers because they're getting to the root of the problems a little bit faster. They're feeling more competent. And ultimately what they say to me is, oh my gosh, I feel so much more purposeful, right? Like one of the pediatricians I was working with said, Amy, I treat tons of asthma. Of course, like that's really important. She said, but I'm never going to get better at treating asthma. I'm really good at it and I've reached the plateau. I can always get better at being trauma responsive. I can always get better of building tools for my patients and my families. I can always get better at pointing out strengths that I see that are inherent to them.
I feel like I've been one big goosebump since we started talking, but really, I have to wonder, a lot of the things you just talked about, they're very subjective, right? Like, how do you measure that this person felt more safe, seen, and heard? And in medicine, the way that we've set up our healthcare system is our operational definitions for things, meaning like how we measure, how we define if something happened or not, or like what a variable is we use stats, we use, the BMI, we use your hemoglobin A1C, like we use all these things. And yet at the same time, I have to wonder, like, are those actual measurements of health, right?
Mm-hmm.
Because I have had plenty of people whose numbers are quote unquote fine,
mm-hmm.
who are obviously not fine.
Mm-hmm.
And it's because their numbers haven't caught up
Right.
with the nervous system dysregulation, with the immune system dysregulation, right?
Mm-hmm.
With the environmental dysregulation that they're having. And so I almost feel like we've gotten in such a habit of going like, okay, we're going to monitor these numbers. And it's so I guess I should say it's reactive,
Mm-hmm.
right?
Mm-hmm.
Okay, well, these things are already off. So how do we fix them? And I went into tertiary care. I went into like, yeah, there's already a problem. Let's fix it. And the more that I learned, I was like, wow, this is where we put most of our money.
Mm-hmm.
I'm like, what would it look like if we put most of our money toward, okay, your numbers are all good. And also like, talk to me about your mental health. Talk to me about how much alcohol you're drinking, right? Because alcohol takes years. Mm-hmm. Cigarettes take years. Inflammation from nervous system arousal takes decades.
Yeah.
And so I love what you're talking about here of like really coming at it preventatively when these kiddos are young,
mm-hmm. Mm-hmm.
because the impact of that is, and that's the other hard part, is it's going to take a minute for us to be able to measure the impact of that.
Mm-hmm. It is. And I mean, your work, my work, anything in the trauma-informed, trauma responsive field is the long game.
Yeah.
And I love what you said, like, how do we measure someone feeling safe, seen, and heard? Can I just tell a couple of stories about what that looks like? So the same physician that I was talking about that said, I'm never going to get better at treating asthma, she was using some of what we call these resilience interventions that I train providers on how to use, right? Again, not just knowing what trauma is, but what do we do about it? And she was teaching them this tool about a parent and a child, how to manage worry, right?
Mm-hmm.
And it's an intervention that I teach called Worry Pie. And for those people that are listening that are psychologists or therapists, they'll recognize it as a very straightforward cognitive behavioral tool, right? That we teach in therapy, but we just boil it down to this quick little 5-minute, here's how we compartmentalize worry. And we really just want you focused on the now versus all the things that already happened or haven't happened. And how do we define that? Anyway, so all of a sudden this provider sees this patient on her schedule again next week. And she was like, oh man, like that didn't help.
No.
But what happened is that the patient, the teenager and the now dad came in, because first time came in with mom. And the teenager was like, my mom really wants you to teach this to my dad too. We all need this. And so they were coming back to be retaught a skill because it felt so profound for them. So that's an example. But another example is this, right? I talk to providers every day who are beginning to talk about trauma, who are beginning to acknowledge intergenerational trauma, systemic trauma from medical complications or being part of a marginalized community that didn't feel heard, parental trauma. And I had this provider say, I've been working with this mom and her 5 children, and sometimes I'm not even sure that she's listening about like how to communicate, how to shift some of this intergenerational harm, how to use more positive discipline. And so I taught her your thing, Dr. Amy, like how do we talk to parents positively about, discipline? And it's really about teaching. And all of a sudden she came in and she was like, this is working. Like my kids are responding differently. There's less chaos in our home. There's less acting out. There's more connectedness. And here's how we will measure it. Those kids who later on in teenage years would show up with a high PHQ-9 or on the Beck's depression inventory or start to have school problems, or these littler kids who are failing developmental screens, because we know that with young children, when there are parental ACEs, they are more likely to fail their developmental screens because of some of the intergenerational trauma that the mom is experiencing. That's where it will begin to show up. As we heal trauma, we will see, not just qualitatively, which I'm a big believer in, but quantitatively, we will start to see screeners, developmental outcomes, later depression, school problems. We will start to see those numbers come down. I really believe we will.
It makes a lot of sense. And, what you said also reminded me of, I was at a networking event earlier in the week, and I was actually talking to an entrepreneur who sells Medicare. And he was like, it's like, you're like, oh, this is such a boring job. And he's like, it's actually so cool because what I get to do is I get to partner with some local value-based care senior citizen organizations or healthcare providers and that are covered by Medicare. And these value-based care providers have gone outside of like the traditional healthcare system and completely changed their model. And by doing that from day one, they're also collecting data. And so we're starting to be able to see that, these value-based care organizations, the way he explained it to me, which I was like, oh my gosh, sign me up for this, please, was, instead of coming to the doctor and you get there at 11, your appointment's at 11:15, you check in, you fill out the same paperwork you filled out 17 times, like do all the things. You don't even get back into the patient room until 11:30. Then you have to wait. Then they're in there for 7 minutes, maybe. And then you leave.
Yep.
He said with these organizations, they actually have a transportation service that is privately owned, or they use Uber and Lyft. And so they ensure that every patient has transportation to, like, they coordinate that.
Right. One of the biggest barriers.
Right. One of the biggest barriers, especially I'm thinking about kids, moms with little kids, like I have to take 2 subways and whatever to get here. It's not happening. Right.
Yep.
If your appointment's at 11, by 11:02, you are in the room with the physician. And guess what? The physician or the nurse practitioner, they're the one taking your vitals. They're the one doing all of those things so that they can personally see the numbers. We don't have those extra people. And they spend 30 minutes with you.
Love it.
And then from there, if you have any issues whatsoever, each doctor has a cap, or each provider has a cap, and every single patient that provider has their personal cell phone number. And so they can text or call whenever they're having an issue. And from there, they can say, okay, I have an appointment. Like I can put you in today, right now. Like I'm sending, they call it the green machine. Like I'm sending the green machine to come get you. They have massively decreased their hospital admissions, their diabetic amputations, like all of these things. And more so, they're spending, even having all of those extra services is way less.
Right.
And they're able to really get to like, I'm lonely. I don't have anyone, I'm living on my own, and my spouse just died and my kids live 3 hours away. And they're like, oh, have you met so-and-so? Right. They have a list for patients like who say, yeah, you can absolutely connect me with other patients in your network.
Incredible.
And I'm like, that is so phenomenal. And even just looking at it like that, I'm like, wow, if we could start to do more of, I'm going to build the trauma-informed, trauma-responsive care. I'm going to see you as a human. I'm going to holistically manage things for you. You're going to have one person who really you trust and and you're not afraid to call them at 2 a.m. because they want you to call them at 2 a.m.
Yeah. Well, and it's such a beautiful model, Lee. And I can already and I know you can feel this too, from all the physicians and providers that I train, I can feel the angst rising, as you say, like they have my phone number.
Yeah.
Let me tell you, in 25 years of my own private practice, seeing thousands of kids and families, very rarely, almost never has that ever been abused, because the acknowledgement that we're in a relationship together and that you have a family and I have a family, but if you need me, I will pick up the phone, hardly ever gets misused or abused.
Yep.
People just like to know and feel honored that they're in a relationship. And by the way, that connection is the number one predictor for long-term health. Number one.
Thank you. Thank you. Because one of the biggest soapboxes that I kept having to pull myself off of, because I was get regulated and talk about this during the pandemic, was the way that we used the term social distancing and not physical distancing.
Yes.
Because and everyone's well, you know, we know what you mean. And I said, yes, but the brain is a fascinating beast. Mm-hmm. And if you keep hearing the term social distancing, even if you cognitively understand mm-hmm. that means you stay 6 feet away from people, mm-hmm. I promise you there's some subconscious stuff going on that says, oh, I'm not going to reach out to this person. I'm going to isolate.
Right. Well, and if we think about what are people's medical literacy, right? So now we have all mm-hmm. of these really important healthcare professionals saying social distancing. And so they're oh, okay, that means I shouldn't see anybody. I shouldn't go around anybody. And so we created a 3-year trial program of social disconnectedness. And it was the most failed human experience of our time.
I feel so sad thinking about what is going to come out of that. And I mean, we are already seeing a lot of the effects of what's coming out of that. But but again, a lot of this stuff takes years. It takes decades, right? And I think of my sister. My sister's also a doctor of nursing practice, and she's more in the education space. And her littlest, I want to say, was 2 or 3 when the pandemic started. So went to preschool
online,
started in a classroom during a pandemic, right? So this child has no context of what things looked like before. Mm-hmm. And my sister called me and she said, you'll never guess what my daughter did. And I said, what? She's I went downstairs and she was playing school with her dolls. And all of her dolls were 6 feet apart. And she was talking to her dolls about the rules of the classroom and how you can't touch each other. And
heartbreaking.
It was heartbreaking. And however you feel about, everyone gets to have opinions about the whole thing. And I think the thing that just felt so disheartening for me was the loss of psychological safety and connectedness mm-hmm. with each other. What are the benefits versus risks of that gonna look like
right.
as it continues to play out? Because there is something about seeing every single other human in your life as a potential threat mm-hmm. and not feeling like you have any safe place to go.
And not even in addition to being a threat.
Yeah.
The fact that we were messaging as a public health system, you could kill your grandma.
Right.
You could, they might be a threat, but you could kill someone. And here's the thing, right? Balancing, we needed to be safe, right?
Yeah.
Still need to be safe, still need to keep people who are vulnerable safe, make, the best decisions you can about vaccines for your family. But at a certain point, we valued that health safety over emotional safety and social connectedness, and in schools with children. And that's why we see more depressed and suicidal teens right now. That's why all of these teachers are calling me, right? And probably calling you saying, are all of children in the world socially delayed? Is it just me?
Yeah.
Because they had no connectedness and normal experiences. And by the way, let us not forget that it was especially for communities of color, communities in poverty, communities that are rural, that were most affected by this. And now it's oh, these people are behind in school. Kids are struggling. It's because we were creating this physical distancing and it had huge effects on large populations.
Our personal family, we have a lot of intersectionality of race and religion and socioeconomic status. And what was really fascinating for me was when watching our personal journey, right? We were lucky, I guess I'll use the term lucky, right? That about 8 or 9 months after the pandemic started, I was able to leave my job at the hospital and the professor role and come home and work my business from home. And my husband was already home. Mm-hmm. He had worked part-time and he worked in a museum that shut down during the pandemic. So we were all home together. Right. Mm-hmm. And so for us, we got to experience what it was like for me to be going out into the world and also for me to be home.
Yeah.
And those were two fundamentally different experiences.
Mm-hmm.
The level of safety that I felt being able to just be at home, even though I really liked going out places, right? But that I wasn't, because those thoughts were in my head as a healthcare provider. I'm like, man, okay, I'm going to work to take care of immunocompromised people. And also, like, before this, I would have, I worked with the stomach flu. I worked with cold, like you were just expected to do that. But now do I go in? Do I do these things? And also, like, I am going into rooms of people with COVID, and then I'm coming home and I have grandparents, that are elder. Like, there was so much, you talk about confidence. There was no confidence.
Yeah.
It was,
terrifying.
I can't figure out which direction to move that actually feels safe. And so when I left, there was a lot of guilt around, like, well, okay, I'm not helping, there's 40 patients a night that needs covered by somebody else. And at the same time, I was like, wow, it's really nice to not have to constantly think about how every decision I'm making feels threatening.
Yes. Yeah.
And
that lives in our body, right?
Yes.
I think, like, what you and I both know, and what I want providers and educators to know is that stress, right? And it was there before COVID, but just got amplified, right? When we experience stress over long periods of time, 9 months, 2 years, 3 years, your life, that stress lives in your body. It's called allostatic load, right? Mm-hmm. We carry it with us generation to generation. It affects our long-term health. Our bodies are not meant to be in long-term states of stress. We are mammals. We are fight or flight, right? We sense a danger and we get the heck out, or we faint, or we freeze, or whatever. The reason people feel and continue to feel, even post maybe physical threat, because they're vaccinated, or it's becoming more endemic than pandemic, is because it's living in their nervous system still. And they haven't processed deep grief, deep loss of connection, well-being. I mean, there's just so much to reconcile at this point.
Yeah. And what I hear you saying, going back to the education and the resources, the tools you're giving to the humans you're serving. I love the trauma and recovery model with Dr. Herman. It's really simple to me. It's very easy to explain to people. And we talk a lot about that first stage of safety, right? And one of the things that I really like to emphasize to the people who come into our spaces, look, like, we got to get you feeling safer and more empowered first. Us processing through any of this is not going to be particularly helpful, and in fact could be even more harmful to try to reduce this, like you said, this allostatic load, to recover from that until you feel safe, because your body's not going to let you let go of it until it's like, I can let go of it. And the other thing is, I love the way that you have set this model up, is that people are able to move into the second and third stages. Like this first piece of safety isn't, this is it and you're done and you're good. Because I see a lot of, I was actually just having this conversation with a client. I see a lot of healthcare and academia places go, oh, you know what? People are feeling unsafe. Let's create a safe space for them, right? Where they can be themselves. And that safe space is the end, not the means to let's process, let's grieve, like, let's get out all of the stuff that you have going on in a way that actually, like, reduces that allostatic load.
Ongoing support.
Yeah. Yeah. Because if I'm like, oh yeah, I've created a space for you and people who look like you and people who sound like you are here and y'all get to come together, and we don't have the capacity to, like, help you. We don't give you resources to feel more empowered, to be able to, like, make different choices. Well, then we're just getting together and having coffee, right?
And maybe doing harm, because we're putting
Yes.
those folks back out into a system. If we use the healthcare system, for example, let's say we create beautiful affinity for people of color or single moms or LGBTQ plus folks, and then we put them back into the healthcare system that's not allowing them to take days off, that doesn't encourage them to, utilize their PTO, that doesn't have childcare available, that doesn't give them basic things like restroom breaks and time to, pump if they're breastfeeding, make sure they're having lunch, feel safe when they're walking to their parking lot, make sure they have adequate lighting. I mean, all of that stuff is what creates ongoing safety.
Yeah. It's not a one-time thing.
Right. Not just being able to check a box and say, oh, we offer affinity grouping at our organization. Not going to be helpful.
Well, and going back to the example you had of the phone numbers, right? I think a lot of, like you said, healthcare providers like, oh my gosh, 200 people are going to have my phone number. Knowing the phone number exists, knowing that I can use the phone number if I need it is a form of ongoing external connection and safety.
Absolutely.
Right?
Absolutely.
And not to take this too far into other spaces, one of the other things that really happened during this pandemic time of loss of physical safety in terms of not only are you a threat to me potentially, but I could be a threat to you. We also had a good amount of deconstruction, destabilization of some other systems that we had seen as safer, more supportive systems in the government, in the legislature, in our enforcement bodies of the rules and the laws. There were all these places where all of a sudden there was a lot of, this used to be something we trust as a general whole. And now, can I trust the things that other people are saying to me? Can I trust that this person who says they're here to help is actually going to help? And I think that it emphasized, and I think just caused a cascade of, okay, where am I safe?
That's right. Yeah. Yeah. I hope too, Lee, is that the burden shouldn't just be on the individual.
Yes.
Where am I safe? The burden is also on the organizations, whether it be legislation or enforcement or schools or healthcare or legislative bodies. The burden should be on them too. Am I creating an environment that is safe? Am I creating an environment that is trauma aware and trauma responsive? Are we looking at systems of healing? Are we looking at historical traumas, right? And saying, how are we moving forward, right? Let's not just return to normal. Let's return better, right? Because normal wasn't working for a lot of people. And so how do we do this better? And it's so interesting to me. I did a program with a colleague around organizational wellness. So, I work with individuals and organizations, and then I do a lot of consultation for big organizations. And when we talked about a wellness model for an organization, there were so many organizations, Lee, that had no way to track what we would call workplace incivilities or oppressions, right? Yeah. They had no way to track it. And then they had no idea, what do I do if it gets reported?
Yeah.
And by the way, then the people who were looking at those workplace violations, if you will, right? Whether it be something small, like being told you couldn't take your time off, to something very big, like systemic racism against a person, right? There were no representation of all voices and all folks at the table to make the decisions about how to handle it. So one of the things that was so rewarding to me to do with several organizations during 2021 was really talk about, what does wellness look like for your organization? And it's not just practicing medicine, right? It's, how do we create physical safety, emotional safety? How do we express gratitude? How do we show appreciation? How do we look at risk? And then when it's not happening, what do we do about it? How are you going to look at this as an organization? That's the only way people, to your point, will begin to feel safer, is if the onus isn't just on the individual any longer, but on the organization as well.
And I love that you're bringing this up, because I think you're speaking to something that a lot of people don't understand about systems and how they get created and the humans who help create them, right? The humans who help create them also have nervous systems. And so if the people creating the systems are dysregulated when they're creating the systems aren't going to promote regulation. right?
Mm-hmm.
And so I think one of the things that feels very scary for leaders is to embark on that journey of looking at where are things not working, because as a leader, it feels incredibly threatening to like open up a can of worms and look at all the places that things are broken and not know what to do with them.
Yeah. Yeah.
And so we get really frustrated. I mean, I remember, being like a brand new staff nurse and being like, why do things happen like this? And like, don't they know that this is, and then going through my doctorate, like sitting in a lot of C-suite meetings and being like, oh, right.
Oh, this is why.
Oh,
Yeah.
this is why. And also I remember the tension in those rooms. Like I have a recent diagnosis of autism. I also have ADHD, and I remember being in those rooms, and I'm a very empathetic person, and I would feel sick after leaving them. And it wasn't about what people were saying. And now I can look back and go like, oh my, everyone was so dysregulated, and I was picking up on all of it.
Absolutely.
And I was like, wow, what would it feel like to create C-suites that when you walked in, you took a breath instead of tensing up?
Yeah. Yeah.
Like what decisions would get made in those spaces?
Well, and that's just it, right? Every policy, every decision, every rule, if you look back on it, is because something really horrible happened. And so then we make a decision or whatever or policy out of fear, right? And that is what you're talking about when you talk about a dysregulated nervous system, right?
Yeah.
And so I'm going back to what you said before about like, how do we measure systems that feel, or someone, but I'm going to say systems now, that feel safe, seen, and heard. Here's the incredible data that came out of this year-long project that we did when we were working with organizations. What we found is when we began to just start at the very bottom of kind of Maslow's hierarchy, right? And just make sure people were getting their lunch breaks, and people had access to water and snacks, and people could ask for, somebody to walk them to the parking lot at night in their hospital parking lot so they felt safe. What happened is that, much to our hypothesis, a rising tide lifted all ships, right? So as people felt physically safer and emotionally safer, and we began to express gratitude, and we began to allow them to take time off, and we began to show appreciation, oh, guess what? Now they felt better as a nurse, they felt better as a doctor, they felt better as a leader, and they could make decisions from a space of safety and wellness versus fear and overwhelm and survival.
And something you said here is like so key, because you're talking about the active practice, right? The implementation of practices that support the message that you are sending to the organization about how you feel, right? Yeah. And I think that this is one of the biggest disconnects that can happen in organizations. We consult more in corporate spaces, and one of the things that we have a conversation about, if an organization says, oh, we're a family, right? And you're using that as your messaging, I'm like, okay, let's talk about that, right? Yeah. How do you define family? What do families do? And we get to remember that every individual who walks in here, if you're not defining what it means to be a family,
right?
They all have their own perceptions of what it means to be a family. And I promise for some of those people, it's not good.
Right. We fight a lot, and there's a lot of support.
Yeah. There's like, we don't respect each other's boundaries. Like, there's a lot of things that people can take from that. And so it's so important to define, okay, when we say this is what we mean. And like you said, take it a step further of, these are not just the policies, right? Mm-hmm. Not just the practice changes we're going to write down on a piece of paper, but like, these are the things we're actively going to change, and here's how we're going to change them. And then I think the last piece is, and I think this actually comes before you do all of this, and I'm curious to hear your perspective, but like figuring out, okay, when this doesn't work for some people, not if, when this thing doesn't work for some people, because I've yet to see a change get implemented that works for 100% of the people in an organization, right? What's going to be our response? How are people able to, how are people able to give us that feedback? How can we create safety around them giving us that feedback? And then how are we going to show people that we are considering that feedback, even if we don't change
Right.
There is an acknowledgement of, we heard you, and here's why we are either continuing in the direction we went, or what we're going to shift.
Mm-hmm. Yeah. I mean, here's the first question that comes to my mind, Lee, and I know it's implicit for you too. Do you have a process about how you collect feedback?
Yeah.
Do people know what happens, what you do with that feedback? But before we even do that, do they even know you have a process?
Yeah.
I mean, there are some people who have been, kind of socialized, systematized to not have a voice. Mm-hmm. And so when you say to that person, well, of course, you should go talk to so-and-so, or it's our policy, and they're like, I had no idea, right? How are we orienting everybody at an organization about, this is our policy, this is our procedure. If you're overwhelmed or need to express grievance, this is how you do it, this is who you do it with, and this is how we will handle it. And I know you said you work a lot with corporations, and when I'm working with organizations, large or small, what I'm saying is you can't communicate too much, right? To close those feedback loops and make sure people understand and feel heard. And you're right, it may not change anything, but they have to, first of all, know that there is a process and they can be part of that process, that their voice matters.
Mm-hmm. And I think ensuring that the process itself is as safe, psychologically safe as possible, right? Because if it's going to risk my job, my income, my opportunity for advancement, right?
Yes. Yeah.
Then I'm not going to participate in your space for feedback. I remember one of the most terrifying moments in my career was I was sitting in clinical. I was working with the interim CNO of the organization. She was my preceptor, and I'm sitting at this C-suite with her, and they were talking about exactly what you're talking about right here. Well, we had an incident where somebody was harmed in a parking lot. So like, how do we help people feel safe? And so they're having this conversation, and I'm listening because I've been a staff nurse and a nurse practitioner in this organization. And I had a look on I must have not fixed my face correctly, because my like the mask slipped, and my preceptor was like, Lee, what do you, I was like, no, I still work here. Y'all still pay me. I didn't say that, but I was like, I'm good. She's like, no, seriously. And the CFO was at the table of the entire medical system. And he was like, I want to hear what you have to say. I said, I got kicked in the stomach when I was pregnant with twins in a patient room, and walked out and tried to refuse the assignment, and they refused to put another nurse with that patient. And then the next morning I got called into my manager's office and threatened with a written write-up for refusing a patient assignment. So you're saying you want us to go to our managers if we feel unsafe. What if the manager is an unsafe human to go to? What would you like us to do?
Yes. Yes.
And they were all just like stunned. And I said, we have to think about, and it goes back to your point of, do we have people at the table who these decisions are going to impact, that can give us valuable information of like, we don't think that's going to work, and here's why. Mm-hmm. Mm-hmm. And can they feel safe enough to say the thing?
Agreed.
I feel like you and I'm excited I get to come on your podcast now. I'll just have to like let everyone know here, like, hey, the Dr. Amy podcast came out, because I'm sure we'll have a really great conversation over there too. I always love to have you share with our listeners, like, where can they find you? Where do you love to hang out on the either internet or in person? Like, where would you like people to connect with you?
Sure. So you can go to my website, www.dramyllc.com, doctor spelled out. You can find all things on there. There's tons of free resources. On my website, you can come and join us in a provider lounge meeting. We host monthly meetings for providers, physicians, dentists, optometrists, and behavioral healthcare providers. So all walks of healthcare providers in a really beautiful connected space, and you get continuing medical education for it. So I would love people to just come and join us and hang out in that community. I'm on all the socials at Dr. Amy LLC, Facebook and Instagram and LinkedIn and all the things. But yeah, I would love people to just join me in one of those spaces and get some free resources and support, and really be part of beautifully connected spaces where we are changing things in how we connect with other folks, how we are connecting with ourselves, and really underscoring the importance of being in a community that feels healing.
I'm so appreciative you came on. I think that the work you're doing, I mean, I can feel the impact just hearing you talk about it. I'm positive that it's exponentially higher when, you're actually in it. So and I'm excited to know that you have the provider lounge, because people are like, Lee, where should we go? And I'm like, you can come with us. And it's not just medical providers, or caring providers. So I'm very excited to send some people your way. So we will make sure that we put the links in the show notes for people to connect. And thank you so much for joining me.
Thank you, Lee. Thank you for everything you're doing in the world too. I can't wait to talk to you more and reciprocate and have you on my podcast as well. I'm so excited.
Oh, I received that. Thank you. All right. Bye, y'all. We will see you next week. Thank you so much for listening to today's episode. Invitation to head to our show notes to check out the offers and connections we mentioned. Or you can just head straight over to institutefortrauma.com and hop in our email list so that you never miss any of the cool things that we're doing over at the Institute. Invitation to be well and to take care of yourself this week, and we'll see you next time.